Okay, so we'll start our discussion. So last time we have discussed about the intestinal obstruction, and there are two types of intestinal obstruction we have discussed. One is called the dynamic type of intestinal obstruction, and the other one is the adynamic intestinal obstruction. That is how we have started. And what is intestinal obstruction? So I just wanted to recall whatever we have done earlier. So what is intestinal obstruction? We have mentioned that when the passage of whatever the bowel content is stopped, or when the passage, there's a cessation of passage, then that is we call intestinal obstruction. So how the bowel contents will stop moving? There are two reasons. Number one, there can be a uh, obstruction, or there can be some there's something that is blocking the lumen. So that is the one of the way. So that is what we call dynamic intestinal obstruction. But even there's the patent, the lumen is patent, still you can have an intestinal obstruction if there are no peristalsis. That is what we have discussed earlier. So when there's a block inside the lumen, we call it is a dynamic intestinal obstruction. And whenever the peristalsis is stopped, or whenever there's an absent peristalsis, then we call it an adynamic intestinal obstruction. So today we will discuss about adynamic intestinal obstruction. Okay. Okay. So there are two types of adynamic intestinal obstruction we have to discuss. Number one is paralytic ileus, and the other one is the pseudo obstruction. Pseudo obstruction. So everybody knows there are a lot of people, they don't know about the pseudo obstruction. So there's one entity we call it a pseudo obstruction. So that is the two types. So usually what will happen, the peristalsis, whenever there's a problem in the small intestine, we call it a paralytic ileus. So adynamic obstruction, mostly it is in the small bowel, we call it a paralytic ileus. That is why the word called ileus, right? So it's a paralytic ileus. So when there's an adynamic obstruction or a peristalsis is affected in the colon, right, mainly colon, then we call it a pseudo obstruction. But there's some small portion of small intestinal pseudo paralysis also it is there, or pseudo obstruction is there, but that is very, very rare. But mostly the colonic pseudo obstructions we will discuss when we consider about the pseudo obstruction. So there are two types of adynamic intestinal obstruction: paralytic ileus as well as pseudo obstruction. So pseudo obstruction can occur in small intestine rarely, but it is mainly affects the colonic part or colon. So first of all, paralytic ileus. We have to discuss about paralytic ileus, that is affects the small bowel. But before we go into the discussion, you can answer some question, true or false question. So you can read true or false question. So paralytic ileus, it occurs in peritonitis. B, it is associated with hypokalemia, or is known to occur following trauma to the spine, and it presents with colicky abdominal pain. So we have to know whether it is associated with colicky abdominal pain, and it is excluded, that is paralytic ileus is excluded when multiple air fluid levels are seen on X-ray. So that is the first question we have to answer. Then the second true or false question, again, paralytic ileus is caused by handling of bowel during surgery, is a manifestation of hypokalemia, or it is occurs in acute pancreatitis, or it is improves in regular high saline enema, and is managed with NG suction and IV fluids until peristalsis returns. So we need to find out what are the true answers and what are the false answers. So we have to discuss them. Next one is the SCQ, the previous past SCQ. You would have done this earlier. So it is again a 60-year-old male presented with abdominal distension and bowel not open for about 3 days duration. On examination, his abdomen was grossly distended and absent bowel sounds. So then again, the questions are, what is the most probable diagnosis? And give 5 causes for his condition and mention the 4 most important investigations we will arrange in this patient. So that is also, it's important. How will you investigate any patients with this kind of a clinical scenarios, and how will you manage this patient? So that is the important things we need to discuss in, it's one of the SCQ. So what is paralytic ileus? Paralytic ileus, it is due to some failure of transmission of peristaltic wave. So peristaltic wave is necessary for the bowel contents to go forward, or it moves. But whenever there's a peristaltic wave it's affected, then we call it a paralytic ileus. So why these peristaltic waves are affected, or peristaltic movements are affected? It is mainly secondary to the neuromuscular failure. So whenever there's a neuromuscular failure is there, the bowel will be paralyzed. So that is what we call paralytic ileus. So this neuromuscular failure can occur in mesenteric plexus, or it can occur in the submucous plexus. So mesenteric plexus, everybody knows there are Aubach's nerve plexuses there, and submucous plexus, there are Meissner's plexuses are there. So whenever it is affected, whenever this neuromuscular failures occurs, people can develop paralytic ileus. So there are various causes, right? There are various causes of paralytic ileus. So we need to understand, and we should know these causes, because whenever patient comes to us with kind of paralysis of the bowel, we should know there are some underlying cause. So we can divide this into systemic causes as well as localized causes. So localized causes, again, we divide it into intra-abdominal causes as well as retroperitoneal or outside the peritoneal causes. So systemic causes, the most common causes are hypokalemia and the uremia. So that is the most important one we have to check in any patients with paralytic ileus, because these are the commonest causes, hypokalemia and uremia. So in a renal failure patient, whenever the patient is having a renal failure, they can have paralytic ileus because of the uremia. Then there are some drugs, right? There are anticholinergic or even laxatives, right? And any Parkinson's disease, any drugs for Parkinson's disease also can cause paralytic ileus, right? Paralytic ileus. So there's an entity called laxative abuse. So what is laxative abuse is, there are some elderly people, whenever they have a constipation, they keep on taking laxatives. So whenever they keep on taking laxatives, what will happen? They can't go to the toilet, or they can't open bowel without any laxatives. So they will be depend on laxatives. So whenever people keep on using laxatives for a prolonged period of time, that laxative can cause us paralytic ileus. Then again, that will aggravate the person's constipation. So that is called laxative abuse, right? Laxative abuse. So you should know laxative also one of the reason for paralytic ileus. Then it's a diabetes mellitus. So diabetes mellitus, again, it will affect the nerves. Everybody knows. So that is also, it is causes paralytic ileus. And hypothyroidism. Hypothyroidism is people comes with the constipation. So that is also one of the reason that will cause us paralytic ileus. And shock. Even if a patient is having a shock with any causes that leads to shock, will leads to paralytic ileus. Then there are localized causes. So we divide the localized causes into intra-abdominal and retroperitoneal. So intra-abdominally, the most common cause is postoperative. Right? Most common cause is postoperative. And then the second cause is intra-abdominal sepsis. And intra-abdominal sepsis also can lead to paralytic ileus. And the third intra-abdominal condition is the gastroenteritis. So in intra-abdominally, the post-operative is one of the most common reason. So whenever any intra-abdominal surgeries, whenever the bowel handling is more, then they can develop paralytic ileus. Right? So that is the most common reason for post-operative paralytic ileus. So whenever after surgery, if a patient's bowel is not open for some time, then that indicate it is a post-operative paralytic ileus because of the bowel handling. Then intra-abdominal sepsis, any infection inside the abdomen, right? Any infection inside the abdomen that can lead to paralytic ileus. For example, a ruptured appendix, right? If somebody is having a ruptured appendix, or if somebody is having a perforated peptic ulcer disease, right? Even there are cholecystitis, right? All these intra-abdominal sepsis can cause us localized or a generalized paralytic ileus. Sometimes there will be a localized paralytic ileus. Sometimes there will be a generalized paralytic ileus. So you could have seen this condition in the wards. So whenever somebody is having an acute appendicitis with the impending rupture or a gangrenous appendix, ultrasound scan shows the localized bowel movements are absent. So that is called localized paralytic ileus. But when the perforation is more and patient develop a peritonitis, then they can develop a generalized paralytic ileus. So intra-abdominal sepsis is one of the main reason that can cause us paralytic ileus. So this is why whenever somebody had an abdominal surgery, even whenever we are suspecting whether there's a perforation or any infection inside the abdomen, we have to ask about bowel opening. So if a patient's bowel is it's normally open, that indicate the chances of abdominal sepsis are less. But if someone is not having a normal bowel opening with abdominal pain or tenderness, then that indicate there's a possible intra-abdominal sepsis. Then gastroenteritis. Everybody knows gastroenteritis. The bowel peristalsis are exaggerated and it will be continuously having a bowel peristalsis. And whenever there's a continuous bowel peristalsis, later on it will causes paralytic ileus, right? So the bowel get tired and it will causes paralytic ileus. So that is also one of the cause for paralytic ileus. When we consider the retroperitoneal causes, the common cause is the pancreatitis. So whenever there's a pancreatitis, so that can lead to paralytic ileus. So whenever there's a patient with pancreatitis, the patient can come with the bowel not open for some time. So that is also one of the important things. Next cause is retroperitoneal hemorrhage. Any reason, any trauma, or even a hemorrhagic pancreatitis. Whenever patient develop hemorrhagic pancreatitis, they can have a retroperitoneal hemorrhage. So whenever there's a retroperitoneal hemorrhage, that also can lead to paralytic ileus. Spinal injury, especially the spine fractures. Whenever there's a spine fractures, not only the spine fractures, even a rib fractures, right? Rib fractures, that's also around the peritoneum. So whenever the rib fractures or a spine fractures, it can lead to paralytic ileus. And anyone having a plaster jacket for any fractures or any immobilization to apply immobilization, they can develop paralytic ileus. So these are the common causes. So always think about the common causes, and always think about there are systemic causes and there are localized causes. And localized causes also, you have to know there are intra-abdominal as well as retroperitoneal. So these are the important causes we should know. Next one, what are the clinical features? What are the clinical features of paralytic ileus? So to recall the mechanical obstruction or a dynamic intestinal obstruction, we have discussed proximal small bowel obstruction, you mostly have vomiting. And distal small bowel obstruction, the people will prominently have abdominal pain, colicky abdominal pain. And colonic obstruction, people mainly have the absolute constipation and the abdominal distension. That is what we have discussed. But in paralytic ileus, even though it is affecting the small bowel, right, it's mainly affecting the small bowel, there will be a marked abdominal distension. So that is the commonest features in paralytic ileus, as well as there will be an absolute constipation, right? Absolute constipation, there's another word for absolute constipation, is called obstipation, O-B-S-T-I, obstipation. So absolute constipation means there's no bowel opening, there's no flatus. So that is what we call absolute constipation. And vomiting will be there because bowel is markedly distended. So abdominal distension is very, very marked. So because of that, whatever the content will be goes as a vomiting. But remember this vomiting is called effortless vomiting. Why? Because it's a this peristalsis is not there. So because of that, the vomiting will appear as a effortless vomiting. So that is the word we call for vomiting occurs in paralytic ileus. Then everybody knows when the peristalsis are not there, the abdominal sounds will be absent. So bowel sounds will be absent. So bowel sounds won't be there in paralytic ileus. But when you compare the dynamic intestinal obstruction, there will be an exaggerated bowel sound. Why? Because of to propel whatever the block, the peristalsis will be more and more in dynamic intestinal obstruction. But when it comes to adynamic intestinal obstruction, the bowel sounds are absent. Then the abdominal colicky abdominal pain, it's not the distension. Colicky abdominal pain is not the feature in paralytic ileus. So everybody understand that. In mechanical intestinal obstruction, people will have colicky abdominal pain. So I have told you about this abdominal pain earlier also. So when the colicky abdominal pain is there, we consider it as a simple intestinal obstruction, simple intestinal obstruction. That is why people develop colicky abdominal pain. When the simple intestinal obstruction becomes a strangulated intestinal obstruction, then the colicky abdominal pain will become a continuous pain, right? Continuous pain. But when there's a paralytic ileus, because there's no peristalsis, the colicky abdominal pain is not there. Colicky abdominal pain is not there. So they can have abdominal pain. So if you get a MCQ says in paralytic ileus, there's no abdominal pain. So abdominal pain is absent in paralytic ileus. That is false, right? That is false because colicky abdominal pain is not there in paralytic ileus, but you can have a pain other than the colicky abdominal pain. For example, intra-abdominal sepsis. For example, perforated appendix. People will have tenderness. People will have pain. Whenever there's a pancreatitis, still people will have pain, burning type of continuous pain. Whenever there's a perforated peptic ulcer or a cholecystitis, they will have a pain, but that pain will be a continuous pain. It is not a colicky abdominal pain. So don't think that paralytic ileus, the pain are absent. No, it is sometimes you can have a pain, but there's no colicky abdominal pain. So in the history, we have to ask about the nature of abdominal pain, whether it is a continuous pain or whether it is a colicky pain. Because if it is a continuous pain, then still paralytic ileus is possible. But in paralytic ileus, colicky abdominal pain is absent. So these are the main clinical features people will be having in paralytic ileus. So how do we investigate, right? So the investigation, we will go for a supine abdominal X-ray. So that is, I have earlier mentioned, it is the gold standard of the basic investigation to identify intestinal obstruction. So in the supine abdominal X-ray, we can see the dilated bowels, right? Dilated bowel loops, and this is mainly a small bowel. So small bowel we can identify with the valvulae coniventous. We have discussed earlier, there are valvulae coniventous, so that indicate there's a small bowel obstruction. So that is why we do supine abdominal X-ray. Okay. So can I ask a question from one? Yeah. So tell me, why supine abdominal X-ray is better than erect abdominal X-ray in intestinal obstruction?
So in supine abdominal X-ray, we can find the site of the obstruction and whether there is any obstruction present. But in erect supine X-ray, we can only find that there is obstruction, but can't find the site of the obstruction.
Okay, good. Yes. So that is why we do supine abdominal X-ray, because you can do two things in supine abdominal X-ray. You can identify the intestinal obstruction, as well as you can identify the level of obstruction, whether it is obstruction is in the small bowel or whether it is obstruction is in the large bowel. So we can identify that. But in any doubtful cases, then we can go for an erect abdominal X-ray. Erect abdominal X-ray will show there are multiple air fluid level. Up to 5 air fluid level is normal, right? Some people say 3, but up to 5 it is normal air fluid level. But if it is more than 5 air fluid level, then that indicates it's a significance, and it is indicate it's an intestinal obstruction. So supine abdominal X-ray we do not to detect paralytic ileus. This is to detect intestinal obstruction, right? So that is why we do supine abdominal X-ray. So that is number one. Second, we have to investigate the underlying cause, right? Why this patient is having a paralytic ileus. That is why we have to do investigation. So if you recall what I have mentioned earlier, the causes we divide it into systemic causes as well as the localized causes. So to detect systemic causes, you have to do a serum creatinine, and we have to do a serum electrolytes, because I have told you blood uremia as well as hypokalemias are the common systemic causes for paralytic ileus. So we have to check the serum creatinine as well as serum electrolytes. Then we have to check the serum amylase to see whether there's any pancreatitis, right? And we have to do ultrasound scan to see whether there's any inflamed appendix or any cholecystitis according to the history. According to the history, we have to find out the foci for intra-abdominal sepsis. So that is why we do ultrasound scan abdomen. So like that. So there are various, even you can do the other investigations. For example, if you're thinking about hypothyroidism, then we can do a TSH. So like that. Whatever the investigation to find out the underlying cause is, again, is important whenever it comes to paralytic ileus. CT scan, is it necessary in paralytic ileus? That will be the question. Yes. CT, if it is a paralytic ileus, is prolonged, right? Prolonged, then we have to go for a CT. So the question is, how prolonged? How long you can wait for paralytic ileus to settle? So that is a question. Anyone, can you tell how long it will be, it can prolong? So usually it is seven days. So we can wait for 1 week. So 7 days, if it is a paralytic ileus is not responding, then we have to go for a CT scan, right? So that is the indication for CT scan. Other than that, all the other investigations are enough to find out the underlying cause, as well as to check whether there's an intestinal obstruction or not. So this is 7 days is the most important one. Next one, when it comes to management. So we have discussed how paralytic ileus presents and how we investigate and what is the management. So when it comes to management, we always restrict the oral fluid intake. Right? We have to restrict oral fluid intake. That is most important one. So whenever you write an essay, right? So most of the people write nil by mouth, right? Nil by mouth. So we usually use that word nil by mouth everywhere in the board or everywhere, but the proper word is the restriction of oral intake. So whenever you write in the essay also, try to write like that, the restriction of oral intake, fluid as well as whatever the solid. And then you have to have a nasogastric suction. So nasogastric suction is very, very important, because that will decompresses the bowel. So decompression of the bowel is, again, it is important. Then the electrolytes should be maintained, right? So electrolyte balance should be maintained in paralytic ileus, because in paralytic ileus, whenever there's an intestinal obstruction, the electrolytes are not absorbed properly. So these electrolytes, even the electrolytes were normal when the person is develop a paralytic ileus, they can deranged later on. So when someone is having a paralytic ileus, always we have to check the electrolytes, right? So that is again one of the important thing. And we have to treat the underlying cause. Then the paralytic ileus will settle. If a patient is having a spine fracture or rib fractures, we have to treat the pain. When somebody is having acute pancreatitis, you treat the acute pancreatitis. Whenever somebody is having a perforated appendix, right, then we have to go for an appendicectomy, or we have to go for a laparotomy and wash out. So like that, whatever the underlying cause, we have to treat. So when we treat the underlying cause, then the paralytic ileus, mostly it is settles. Okay, so that is the most important management in paralytic ileus. So in paralytic ileus, can we have strangulation? So in paralytic ileus, what will happen? The blood supply to the bowel wall is blood supply to the bowel is through the bowel wall. So whenever there's a bowel wall is compressed, right? Compressed, what will happen? Whatever the blood supply, the blood is supplying to the bowel wall will be compressed. So why this compression occurs? Because of the increased distension. When the bowel is distended very much, what will happen? That will compress the blood supply of the bowel wall because of the compression there, right? Because of the compression to the bowel wall. I'll show you. So when the bowel is distended and it is compressed, all this blood supply will be compressed. So can you see, everybody see this one? So here see, this is the normal bowel. So it is in the normal bowel, inside is a lumen. So consider this is the lumen. So this lumen and all this blood supply, these small red spots are blood supply. So that is how it is traveling inside the bowel wall. But when the distension occurs, the bowel will compress all these vessels. So whenever bowel compress all these vessels in the periphery, all these vessels will be blocked. So when it is compressed, that supply, the bowel supply will be affected, and that can go into strangulation though. So that is how people develop strangulation when it is comes to paralytic ileus. So paralytic ileus can leads to strangulation anytime. So that is everybody should remember. So that is the important one. Okay. So management already we have discussed. The restriction of oral intake is very important. Nasogastric suction, that is why I told you nasogastric suction is very mandatory to decompresses the bowel. If you don't decompress the bowel, what will happen? The bowel can go into strangulation. Then the electrolytes should be maintained properly, because if you don't maintain the electrolytes properly, that is also will leads to aggravation of the condition. And we have to treat the underlying cause, or find out the underlying cause, and then we have to treat, right? We have to treat. So that is the management of paralytic ileus, right? That's the management of paralytic ileus. So when we consider the indications for laparotomy, there are mainly two indications there. Number one, paralytic ileus persists more than 7 days. So I told you, if it is a paralytic ileus is persists more than 7 days, we have to go for a CT scan. So with the CT scan, then we have to go and we have to manage the, we have to go for a laparotomy to find out whether there's any other pathology inside the abdomen. So we need to go for a laparotomy in that case. So that is one of the indication. And the other indication is, if a bowel sounds are normal after surgery, for example, patient has undergone an abdominal laparotomy. So after the laparotomy, patient comes to the ward, and when they comes to the ward, if a bowel is not open and bowel sounds are absent, that indicates it's a post-operative paralytic ileus. Everybody knows that. Already I have mentioned. But if a bowel sounds are normal after reappears after the laparotomy, after laparotomy, patient comes and second day bowel sounds are normal, patient open bowel, then after 2-3 days again the bowel sounds are absent, then that is not due to post-operative just the bowel handling. So that kind of a people, we have to go for a laparotomy again. So there are two indications for laparotomy in paralytic ileus other than the underlying cause. Other than the underlying causes, paralytic ileus persists more than 7 days, we have to go for a laparotomy. And if it is a bowel sound appears after abdominal surgery and then again it stops, then again that is also needs for laparotomy. So these are the main indications for laparotomy in paralytic ileus. So next condition is the pseudo obstruction. I already told you pseudo obstruction is the other adynamic intestinal obstruction. So pseudo obstruction mainly affects the colon, but sometimes it will affect the small bowel as well. So what is a pseudo obstruction? So pseudo obstruction is whenever there's an intestinal obstruction with an absence of mechanical cause, or the acute intra-abdominal diseases, any intra-abdominal sepsis or intra-abdominal diseases, and anyone is having an bowel obstruction with absent peristalsis or absent bowel sounds, then that is considered as pseudo obstruction. So it is usually associated with various syndromes, right? There are some syndromes that can lead to pseudo obstruction. In that people, there can be a neuropathy, so they can have a congenital neuropathy problem, so they can have some myopathies, or sometimes it is multifactorial. There are some other factors also can lead to pseudo obstruction. So it is multifactorial. So there are mainly two varieties, right? There are mainly two varieties. One is called small intestinal pseudo obstruction, that is affects the small intestine, and the colonic pseudo obstruction. So first of all, small intestinal pseudo obstruction. We will consider small intestinal pseudo obstruction. So you should know the difference between paralytic ileus and small intestinal pseudo obstruction. So what is the main difference? Paralytic ileus, there's some reason why patient developed paralysis of the bowel. There should be some reason. There will be some underlying cause. But when it comes to pseudo-intestinal obstruction, most of the time we can't find the underlying cause. Most of the time we can't find the underlying cause. So that is what we call it's a small intestinal pseudo-obstruction. It can be secondary. Sorry, it can be primary or secondary. So usually this kind of a people, they present with the recurrent subacute obstruction. So they will pass open bowel, then again it stops, then again they pass, or like that. So they will have a recurrent subacute obstruction. So it is usually diagnosed by the exclusion of whatever the mechanism or whatever the underlying cause. So whenever we exclude all these underlying causes, then that is, we will confirm it's not a paralytic ileus, it is a small intestinal pseudo obstruction. So that is how we diagnose this condition. So usually if we find some underlying disorders, right, it's not underlying diseases, we call it a disorder because it can be associated with some syndromes. So whenever we identify that kind of a syndromes and a disorder and we correct whatever the problem, then it will resolve small intestinal pseudo obstruction. We can give a metoclopramide as well in pseudo obstruction. Metoclopramide is one of the drugs can be used. It is not very effective, but it can be used, and sometimes erythromycin also it is helpful in small intestinal pseudo obstruction. So remember, all the other intestinal obstruction, we don't give metoclopramide. We don't give metoclopramide in any other intestinal obstruction to stop the vomiting or to increases the bowel movement. But in small intestinal pseudo obstruction, there's a place for metoclopramide. So that is what we have to know, but we have to exclude all the other underlying causes or underlying diseases, then it will comes into small intestinal pseudo obstruction. So colonic pseudo obstruction, there are two types. You can have an acute colonic pseudo obstruction, or it can be a chronic colonic pseudo obstruction. Acute, there's another name, it's called Ogilvie syndrome, right? You should know this one. Sometime they might ask it can appears in the MCQs as well, Ogilvie syndrome. So you should know Ogilvie syndrome is a colonic pseudo obstruction, right? So, and it is acute, and it is sometimes it's chronic. Colonic pseudo obstruction can present as chronic problem for a prolonged period of time. So people can come with the constipation and bowel sounds absent, and whenever you find some underlying cause, all it is absent. So that is called chronic colonic pseudo obstruction. And the most important problem or most important complication with colonic pseudo obstruction is cecal perforation. So they can go into cecal perforation in colonic pseudo obstruction. Again, the bowel is distended because there's no passage of bowel content, so it will go into cecal perforation. So what are the investigations? So investigation wise, we have to do urgent colonoscopy to exclude any underlying cause. So if it is any underlying cause, it's mechanical or anything, then there's a reason for obstruction, and there's a reason for adynamic obstruction. But if there's no reason, then we have to confirm that with the urgent colonoscopy. So if we can't do an urgent colonoscopy, then we can go for a single contrast water soluble barium enema. So that's also one of the option, or we can go for a CT scan as well. So remember, you don't have to do all these three in investigation. Either we can go for a colonoscopy, or if that is not available, we can go for a single contrast water soluble barium enema, and we can go for a CT scan as well. Treatment, when it comes to treatment, so we have to treat any identifiable causes, right? So that is the important one. Anything we identify, we have to treat. So that is the most important one. So if it is identifiable causes are not there, right? Not there, so that is the pure colonic pseudo obstruction, then we can give a intravenous neostigmine, right? Intravenous neostigmine is the management for colonic pseudo obstruction. So usually it is intravenously we give 1 milligram, right? 1 milligram, one dose, and then wait for a few minutes. And if it is not responding in with that few minutes, then we have to give another 1 milligram of neostigmine. But during we give a neostigmine, patient should be in the coma, right? So everybody knows that, because when we give a neostigmine, immediately the patient's bowel will be open, so patient will be on the coma. At the same time, patient will be monitored with ECG monitoring. So ECG monitoring should be there, and the atropine should be ready, right? The atropine should be available with the patient, near the patient, because anytime that if a patient goes into bradycardia, we have to give some atropine. Reverse the neostigmine effect, we have to give some atropine. So these are the important things. So intravenous neostigmine is important, and patient should be on the coma, and the ECG monitoring should be there, as well as the atropine should be available whenever we give intravenous neostigmine. Even if it is not responding with that, then we have to go for a colonoscopic decompression. So we have to do colonoscopy, and then we can go for a decompression. Most of the cases will settle with this, right? With conservative management, not conservative management, we call this is a non-operative management. So most of the people will be settled with non-operative management. Operative management, that is laparotomy, is dangerous because that will cause us high mortality, right? The laparotomy will cause us high mortality. So because of that, we usually go for a non-operative management. But there are two indications for laparotomy. Number one, the cecal diameter, if it is more than 14 centimeter, right? If it is 14 centimeter or more than 14 centimeter of cecal diameter, that called impending rupture. Impending rupture means anytime the cecum will rupture, then you can't wait, then we have to go for a laparotomy. Or cecal perforation, already the patient develops cecal perforation as a complication, then again we have to go for a laparotomy. So these are the two indications for laparotomy in colonic pseudo obstruction. Cecal diameter is more than 14 centimeter, or if you detect a cecal perforation with the colonic pseudo obstruction, whenever we manage, the patient is not responding, and then patient develop a cecal perforation, then we have to go for a laparotomy. So these are the two important management for colonic pseudo obstruction. Okay. So treatment of any identifiable cause, I have mentioned earlier, in the treatment, the first treatment is treatment of any identifiable cause. So what are the identifiable cause? There are several factors that can lead to colonic pseudo obstruction like paralytic ileus. So paralytic ileus, I had told you, it is mainly affects the small bowel, and colonic pseudo obstruction mainly affects the colon. So like paralytic ileus, that same uh, same, and as well as there are multifactorial factors affects or causes pseudo obstruction in colon as well. So it can be metabolic. Everybody knows it is there. The table is there in the Bailey and Love, so you can see from the Bailey and Love the same thing. I took it from the Bailey and Love. So factors associated with pseudo obstruction may be metabolic, or it may be due to severe trauma. Shock can cause pseudo obstruction again. Sometimes you can't find a cause, so it is idiopathic. Even septicemia, post-operative with the lower pelvic problems, or mainly the femur fractures, retroperitoneal problem, drugs, or any secondary gastrointestinal involvement. Anything that can lead to colonic pseudo obstruction. So that is the treatment of an unidentifiable cause. So any identifiable cause we treat. If it is if there's no identifiable cause, then we have to treat with intravenous neostigmine. And if it is not settled with that, then we have to go for a colonic decompression, and then we have to go for a laparotomy if there's no improvement. And if it is a cecal perforation is suspected, or whenever the cecal diameter is more than 40 centimeter, then we have to go for a laparotomy. Okay. So that's all about the adynamic intestinal obstruction. So anyone comes with an intestinal obstruction, right? It's a clinical, we'll consider it's a clinical discussion. So if someone comes with an intestinal obstruction, the first thing we have to find out whether he is having an intestinal obstruction or not. The last time I have mentioned. So how can we identify? There are features. So patient will be having abdominal distension, absolute constipation, they will have a vomiting, and there will be a colicky abdominal pain in mechanical obstruction, and there won't be any pain in paralytic ileus, but the other features will be there in both conditions. So then number one, find out the cause for, find out whether it is an intestinal obstruction. Second, we have to find out whether it is a simple intestinal obstruction or a strangulated intestinal obstruction. So if it is simple, then it is not a problem. We can wait and we can investigate. But if it is a strangulated, then we have to go for a laparotomy. Right? We have to go for a laparotomy. Then we have to, if it is a mechanical intestinal obstruction, we have to find out whether its cause is due to loaded bowel or a hard bowel. Sorry, loaded bowel or a hard stool. So for that, we have to do a digital rectal examination for every intestinal obstruction patient to see whether there's any hard stools in the rectum or not. And if it is a rectum is empty, that means the intestinal obstruction is not due to hard stools. Then our main worry is if it is a mechanical intestinal obstruction, we have to exclude scar, that is abdominal surgery, as well as obstructed hernias. Obstructed hernias also can cause intestinal obstruction. So we have to check the abdomen to see whether there's any scar, and we have to check the hernial orifices, whether there's any obstruction there. Okay. So these are the mandatory steps whenever somebody comes with an intestinal obstruction. So the history and examination find out whether it is an intestinal obstruction. Second, check whether it is a strangulated intestinal obstruction or a simple intestinal obstruction. Third, check whether the rectum is empty or rectum is loaded. And fourth, check whether it is a abdominal scar is present or not, and the hernial orifices are there or not. Then listen the bowel sound and see whether it is an exaggerated bowel sound or an absent bowel sound. Exaggerated bowel sounds, maybe it is due to mechanical intestinal obstruction, and absent bowel sounds, it may be due to paralytic ileus. So if you get a single best answer question, single best question, in the single best question, if somebody mentioned the patient comes with an abdominal pain and bowel not open for 3 days and all kind of things, and whenever you examine, the bowel sounds are absent. So in this case, it is a paralytic ileus due to some intra-abdominal condition. So what are the intra-abdominal condition? It may be a perforated peptic ulcer or perforated appendix or acute pancreatitis. That's why patient comes with an abdominal pain and bowel not open. So I have seen in the wards, right? Most of the time in the ward, whenever this kind of a patient comes, people uh, treat that patient as an intestinal obstruction, right? So you can treat with an intestinal obstruction, but if a bowel sounds are absent, and if a patient is having an abdominal pain, then always you have to find out there's some perforation or there are some intra-abdominal sepsis is going on. Then patient has to go for a laparotomy. So this is why how we decide whether the paralytic ileus we go for a laparotomy early or whether we treat them for 7 days. So that is the important things everybody knows, everybody should know. We'll go for the questions again, whatever we have started with. So paralytic ileus is occurs in peritonitis. Yes. So whenever there's a peritonitis, always we have to uh, uh, check for absent bowel sound. So paralytic ileus can be there whenever there's a peritonitis. So is this associated with hypokalemia? Yes, it is one of the commonest systemic cause we have discussed. The other one is uremia. So hypokalemia and uremia should be excluded whenever somebody is having a paralytic ileus, and is known to occur following a trauma to the spine. Yes, we have discussed retroperitoneal causes, that trauma to the spine or spine fractures, they can develop paralytic ileus. Even rib fractures, not only the spine, rib fractures also that can cause paralytic ileus. And it presents with colicky abdominal pain is false, because paralytic ileus we have discussed, colicky abdominal pain is not the feature, right? It is not the feature. And paralytic ileus is excluded when multiple air fluid levels are seen on the X-ray. Again, it is false, because you can't exclude, right? You can't exclude whenever there's a air fluid level is there. It can be a mechanical obstruction or it can be a adynamic intestinal obstruction. Only we can say with the multiple air fluid level is there's an intestinal obstruction. But whether it is a dynamic or adynamic, you can't differentiate. So that is false. Next one, paralytic ileus is caused by handling of bowel during surgery. Yes, that is one of the commonest intra-abdominal cause for paralytic ileus, handling of bowel as well as the recent surgery. It's a manifestation of hypokalemia. Yes, true. It occurs in acute pancreatitis. Yes. So again, one of the important things I will tell you, patient comes with an intestinal obstruction, and people treat the patient with intestinal obstruction without checking whether the patient is having an acute pancreatitis in most of the conditions. But that is wrong, because if a bowel sounds are absent, we have to find out there's the underlying cause. Where is the underlying cause? So in that, if a patient complains of abdominal pain, we have to check the serum amylase as well to see whether it is related to acute pancreatitis. It improves with regular high saline edema. No, paralytic ileus is involved in the small bowel. So because of that, whatever the enema we put, it is not resolving the paralytic ileus. So that is false. Is managed with NG suction and IV fluids until peristalsis returns. Yes. So usually we wait for about 7 days with NG suction and IV fluids in paralytic ileus. So most of the paralytic ileus, if you treat the underlying cause and if you treat with NG suction and IV fluids, within 7 days, most of the paralytic ileus will settle. And if it is not settled within that 7 days, then we have to go for a CT scan. And with the CT scan, we have to find out any other underlying cause is there. And then we have to go for a laparotomy in paralytic ileus. So we give NG and IV suction until peristalsis returns is true. There are SCQ question again. 60-year-old male presented with abdominal distension and bowel not open for 3 days duration. On examination, his abdomen was grossly distended and absent bowel sounds. So everybody should know this is due to paralytic ileus, because the reason in the question we have mentioned it is paralytic ileus is one is abdominal distension and bowel not open. Marked abdominal distension is the perfect word to use in paralytic ileus, and bowel is not open for about 3 days. Again, that indicate it is intestinal obstruction, and absent bowel sounds is indicate it's a paralytic ileus. What is the most probable diagnosis? So your diagnosis should be paralytic ileus.